Welcome back to the deep dive. Today, we are opening up the literature on what is, well, arguably the most demanding challenge in soft tissue orthopedics, trying to replicate or regenerate the meniscal scaffold.
Exactly. This is really our pre-op conference review for that symptomatic meniscal deficient knee. We're
Yeah.
moving way beyond just a simple partial meniscectomy here and looking at the advanced stuff, the synthetic substitutes, the collagen scaffolds, everything that promises, genuine regeneration.
Right, or at least a stable substitution. And our mission today is to give you, the listener, a shortcut to really understanding this field. We're going to unpack the material science, get into the hyper-specific surgical indications, and I think most importantly, we need to critically analyze the long-term data.
To see if we're offering a real fix or just, kicking the can down the road toward a total knee.
Precisely. So let's start with the basics, because understanding why the meniscus is so incredibly hard to replace is it's the key to understanding why so many of these scaffolds can fail.
It is. When you ask a patient what the meniscus does, they almost always say it's a shock absorber.
Which vastly undersells its role.
Oh, completely. Calling the meniscus a shock absorber is like calling a skyscraper a pile of bricks.
Yeah.
It's fundamentally missing the point. The menisci are these critical wedge-shaped fibrocartilaginous structures. They are the absolute biomechanical workhorses of the knee.
And their main job is load distribution. They increase that contact area by, almost 300%?
Which in turn just massively reduces the stress on the articular cartilage. And the mechanism behind that, that's the real genius. It's all in the architecture.
The collagen fibers.
The collagen fibers. When you stand up, when you walk, the femur tries to push the meniscus outward to extrude it. But you have these huge, circumferentially oriented type psi collagen fibers in the body of the meniscus that resist that push.
And that resistance creates the hoop stress.
That's the term, yeah, hoop stress. It basically transforms this massive vertical compressive force into a tensile load that's distributed all across the rim.
Think of it like tightening the metal hoops around a wooden barrel. The water inside, that's the joint load, is trying to push the staves out, but the hoops keep everything contained and rigid.
It's a perfect analogy. And if a surgeon removes that peripheral rim, or critically, the root attachment, you've just cut the hoop.
And the barrel explodes.
The barrel explodes. The load suddenly focuses on this tiny, tiny area of articular cartilage. And that leads directly to sky-high peak stresses, cartilage damage, and meniscal extrusion. The whole system relies on those anterior and posterior insertions and that peripheral ligament attachment. They are the anchors.
So any scaffold we put in there has to not only withstand these huge hoop stresses from day one, but also integrate fast enough to not just tear out. That is a really tall order for something that's basically a collagen sponge.
It is. And the complexity, it just deepens when you look at it microstructurally. The meniscus is, it's inhomogeneous and anisotropic.
Meaning its composition and its properties, they change depending on where you are in the meniscus and in which direction you're pulling.
Right. And this is where most engineered scaffolds just can't keep up with what nature figured out.
So detail that gradient for us. Why can't we just make the whole thing out of one really strong material?
Because the job changes from the outside to the inside. If you look at the peripheral vascularized zone, the red zone, the part that can actually heal, it's dominated by that superorganized type I collagen. It's built for tension.
Right. The cells there are more like fibroblasts, but then you move inward.
You move to the inner avascular zone, the white on white, where tears never heal, and the tissue completely changes.
It becomes much more like hyaline cartilage.
Exactly. You see type 2 collagen and a huge increase in GAGs, glycosamoglycans, and proteoglycans. The cells look more like articular chondrocytes,
Right.
and that higher JAG concentration is absolutely critical because they're hydrophilic, they pull in water.
Which allows that inner part to absorb and resist compressive loads. So any successful scaffold has to somehow mimic that transition. Type I on the outside for tension, type 2 on the inside for compression.
That's the fussy architect we're all trying to impress. Which, brings us to the original biological problem. Why doesn't the meniscus just regenerate on its own?
It's a developmental story, isn't it?
It's a developmental regression, which is why it feels like such an impossible hurdle. When you're in utero and even into infancy, the meniscus is fully vascularized. It has blood supply everywhere. But as you grow, the body systematically and purposely pulls that vascularization back.
It's an intentional decommissioning of the blood supply.
It is. The body decides this inner part doesn't need blood. It needs hydrostatic pressure resistance. And once that central zone is avascular, any tear there is biologically inert. It has no potential to heal. So our challenge is to get cells and blood back into a zone that the body spent years shutting down.
So the material scientists are basically trying to reverse millions of years of evolution. What are the three ideal characteristics they're chasing in a scaffold?
Okay, so first, the scaffold needs to be a matrix that's amenable to tissue ingrowth. That means the right pore size, good interconnectivity, but, and this is the hard part, it has to maintain near-native compressive stiffness right away.
Because that initial stiffness is what gives the cells the right signal. You called it a profibrachondrogenic biophysical effect.
Right, that's the term. It means the mechanical stimulus itself tells the ingrowing cells to become the right kind of cells, fibrochondrocytes, and not just, useless scar tissue.
So it's a contradiction. It needs to be tough enough to handle body weight, but porous enough for cells to move in.
It's a huge contradiction. The second requirement is that it has to withstand that complex loading environment for months while it's regenerating without failing. And third, and this is the real holy grail, it must facilitate that zonal regeneration, somehow signaling for type I on the outside and type 2 on the inside.
That third point seems almost impossible.
It is. But before we even get to the fancy materials, we have the fundamental clinical hurdle for every single option we have today. They all require an intact peripheral rim and stable root attachments.
Non-negotiable containment.
If that rim is gone, or the roots are unstable, say, from a total meniscectomy, these scaffolds have zero chance. They just extrude immediately. And in those cases, meniscal allograft transplantation, or MAC-GAT, is still the only game in town.
And that distinction is what drives patient selection for the next two scaffolds we're going to talk about. So let's start with the one with the most history, the CMI, which used to be called Metaflex.
Yeah, and its regulatory journey in the U.S. is a perfect example of how clinical science and, regulatory issues can sometimes clash.
It got approved, then pulled, then reapproved.
It was approved in late 2008, then withdrawn in 2010 for reasons that were totally non-clinical. It had nothing to do with safety or efficacy data. It was an administrative issue with the manufacturer.
Which caused a lot of confusion. But thankfully, it was reapproved in 2015.
And crucially, Europe never stopped using it, which is why we have this fantastic continuous stream of long-term data from them for over a decade.
So the material is bovine Achilles tendon mostly, type I collagen. How do you turn something that tough into a pore scaffold designed to attract cells?
It's a meticulous process. They start by harvesting and purifying the tendon to isolate those type I collagen fibers. Then they physically swell them with these critical precursors, hyaluronic acid and chondroitin sulfate.
The JAGs and proteoglycans, so they're basically preloading the scaffold with the ingredients it needs to resist compression.
Exactly. That HACS slurry is key. And the whole mixture is lyophilized or freeze-dried to create the porosity. But the most critical step, I think, is that it's manually oriented in a mold.
To mimic the circumferential fibers of the native meniscus.
Right, to give it that initial hoop stress capability.
Right.
Without that, you just have a random pile of fibers, and it would fail under tension immediately.
So what you get in the end is this acellular scaffold. It's a biocompatible skeleton just waiting for cells to move in.
The whole point is that it's a temporary structure. It's designed to pull in cells from the vascularized rim, from the synovium, from the synovial fluid, and support that de novo tissue growth. It's a very delicate balancing act between having immediate strength for fixation and being porous enough to be an invitation for those cells.
And the preclinical work in dog models showed this could work. But in the clinic, success or failure really comes down to one thing.
Patient selection. It is the single most important factor. The indications are incredibly specific. A symptomatic medial meniscus deficiency, usually chronic post-meniscectomy syndrome.
And what are the absolute non-negotiable prerequisites?
Containment. You must have an intact peripheral rim and stable root attachments. If you don't have those, the implant will just extrude. It's useless.
It's like trying to rebuild a tire with a massive hole in the sidewall. It just won't hold pressure.
And then you have to address all the coexisting pathology. Any significant malalignment needs an HDO. Any instability, like an ACL tear, has to be fixed. You can't ask this little scaffold to save a joint that's failing in 3 other ways.
Okay, now for the red flags. The contraindications, these are the patients we have to turn away.
The list is pretty long because we're chasing a biological win here. So uncorrected instability is out. High-grade cartilage lesions are out. A total meniscectomy obviously is out. Moderate or severe arthritis, that's a contraindication.
And the one that consistently comes up in the data.
Increased BMI. The data just hammers this home. A BMI over 25 kilograms per meter squared negatively impacts the outcomes.
And why is that? It's just too much load on a healing structure, right?
Oh, it's pure mechanics. Increased PMI means significantly higher peak forces across the joint, and that translates to excessive shear and compression on a scaffold that, for the first few months, is fundamentally weak. It's just relying on gentle cellular ingrowth. High load just destroys that newly forming matrix.
Makes perfect sense.
Yeah.
So let's walk through the surgery. What does the actual procedure look like?
It's all arthroscopic. First, you have to meticulously debride the defect right down to the vascular zone of the rim. You need a good bleeding bed to recruit those cells. Then comes sizing.
And you have to use those special measuring devices. It's not something you can just eyeball.
Not at all. You use a flexible measuring device to precisely map the defect. The CMI implant comes as a flat sheet, and you have to trim it on the back table to fit perfectly. You're trying to maximize the contact area between the native rim and the implant.
Anyone who's done one of these knows it's like wrestling a floppy piece of rawhide underwater, trimming it and getting it seated arthroscopically. It takes a lot of patience.
Extreme patience. Once it's in place, fixation has to be bomb-proof. We're using 2-0 non-absorbable sutures, a combination of inside-out, outside-in, and all-inside techniques. Usually vertical mattress sutures to the rim for maximum stability.
And that stable fixation is the only thing preventing extrusion for the next 6 months. Because right after surgery, the patient starts that grueling rehab protocol, what we call the tightrope walk.
This is the implant protection phase, and it demands 100% compliance. Patients are kept strictly non-weight-bearing for 6 full weeks.
6 weeks. That is a massive lifestyle interruption. We're asking them to sacrifice their immediate mobility for long-term biological success.
And that 6-week window is biologically necessary. You need that time for the early fibrovascular integration to create some shear strength. If they load it early, the sutures will likely tear or the implant will just collapse.
And motion is limited too.
Oh, yeah. Usually to 60 degrees of flexion for the first 4 weeks, then up to 90 until the 6-week mark. Unrestricted activity isn't really advised until at least 6 months post-op.
So if a patient isn't going to commit to that, the whole surgery is basically a waste of time.
Pretty much. You have to delay the return to sport to prevent a return to the OR.
All right, let's get into the evidence. The Rodkey et al. Study from 2008 is still the absolute landmark trial for CMI.
It's the gold standard. A big prospective randomized trial, over 300 patients, comparing CMI to just a partial meniscectomy. And the first question was simple. Does this thing actually grow new tissue?
And the answer from the second look arthroscopies at 1 year was a definitive yes.
A definitive yes. They found a significant increase in meniscal tissue surface area in the CMI group. So it wasn't just a temporary plug. And the histology was even more compelling. The biopsy showed fibrochondrocyte-like cells inside lacunae actively generating new matrix.
So the scaffold was actually being assimilated, not just walled off by scar tissue.
Exactly. And there was no sign of an immune reaction, which showed excellent biocompatibility. But from the patient's perspective, the really strong finding was in the chronic CMI group.
That's the patient we're really trying to help, the one who's been suffering for years after an old meniscectomy.
And that chronic CMI group showed a statistically greater gain in their activity level, the Tegner index, compared to the controls. So restoring that volume translated directly into better function.
Now, imaging is how we track this non-invasively. How do we follow the incorporation on an MRI?
So Genovese and his colleagues developed specific MRI criteria. Early on, say at 6 months, the CMI is super hyper intense.
It stands out like a neon sign because it's still mostly scaffold and fluid.
Right, we call that a type 1 signal. But over time, as it incorporates, we see a progressive reduction in that bright signal. By 24 months, about a quarter of the patients had an implant that looked very similar to a normal mature meniscus, a type 3 signal. You could literally watch it mature on the scans.
Okay, now for the long game. The 10-year data, mostly from Europe, is what really validates the whole concept.
The Zaffagnini study is powerful. At 10 years, the CMI patients had significantly lower pain scores and higher functional scores compared to the partial meniscectomy controls.
But the real clincher is always the chondro protection. Did it save the cartilage?
That's the key. Radiographically, they saw significantly less medial joint space narrowing in the CMI group over that decade. If we can prove that restoring meniscal volume actually shields the articular cartilage from arthritis, that is the ultimate measure of success.
And the Monlaw study backed this up. What was their failure rate at 10 years?
It was incredibly low. Only 8% of the implants, that was 2 out of 25 patients, needed to be revised to a meniscal allograft. A 92% survival rate at 10 years in this high-risk population is extremely encouraging.
So the takeaway for CMI is that it works, but only if you stack the deck in its favor. Perfect patient selection, addressing all the other mechanical issues, and a super strict post-op protocol.
Correct. The success isn't just in the scaffold itself. It's in the meticulous application of the scaffold in the ideal biological and mechanical environment.
Okay, let's pivot now to the synthetic contender, ActiFit. This is a porous, biodegradable polyurethane scaffold. It's used all over Europe, but it's still waiting on the FDA here. How does using a synthetic polymer instead of bovine collagen change the game?
Well, the main difference is the control you have over the material. Because it's fully synthetic, it's manufactured to these highly controlled specifications. The design is all about maximizing cellular infiltration. It has a very high porosity, around 80%, with pore sizes in a very specific range, about 150 to 355 microns.
And why is that specific pore size so critical?
It's that classic tissue engineering sweet spot. The pores need to be big enough for cells and new blood vessels to migrate in, but if they're too big, the whole thing loses its initial mechanical strength and just collapses. So that range is considered optimal.
And the preclinical journey for ActiFit taught us a pretty important lesson from its failures.
Yeah, the early work by Kinnan and Welsing is really instructive. They initially tried to use ActiFit as a total meniscal replacement in dogs. And while it integrated biologically, it failed mechanically. They couldn't get adequate fixation, and the articular cartilage just degenerated.
Which just reinforces that rule. Containment is king. Even with a sound material, if you can't anchor it, the joint's biomechanics will win and destroy the joint surface.
Which is exactly why the focus now is wisely limited to partial meniscal replacement, requiring that intact rim and horns, just like the CMI.
So the big clinical evidence comes from the Verdonk et al. Multi-center trial. Tell us about that group of patients.
It was a really challenging cohort. 52 patients, and almost 90% of them had already had previous knee surgeries. These were chronic, symptomatic people. But the follow-up showed really rapid tissue ingrowth.
How rapid?
They confirmed tissue ingrowth in all the subjects they scoped at 12 months. And biopsies confirmed it was the right kind of tissue, collagen, fibroblasts, fibrochondroblast-like cells.
So the synthetic scaffold is basically acting just like the bovine one, as a passive platform for the host tissue to come in and build a meniscus-like structure.
Exactly. And the critical finding, just like with CMI, was the chondroprotection. They saw stable or even improved ICRS cartilage grades in over 92% of patients at 24 months.
Okay, let's unpack that for the audience. What does a stable or improved ICRS grade actually mean for the patient's future?
The ICRS is how we grade cartilage damage, from grade 0, which is normal, to grade 4, which is bone-on-bone arthritis. Seeing stability means we are stopping the progression of the disease. We're preventing those early grade NITs or 2 lesions from becoming the end-stage arthritis that needs a joint replacement.
That's the real goal. But it seems like ActiFit has a slightly higher complication profile.
It does, at least in that early data. The reoperation rate was 17% at 2 years, which is not insignificant. And the failures were more common on the lateral side.
Which makes sense. The lateral compartment is inherently more mobile, less constrained. It just puts a higher mechanical demand on any implant trying to integrate there.
And that brings up the issue of concomitant procedures. A lot of these patients also have malalignment, usually a varus knee that needs an HTO. Gelber and his group looked at combining ActiFit with an HTO.
So did adding the scaffold actually provide more benefit in the short term?
And this was a fascinating and kind of humbling result. They found that combining ActiFit with an HTO did not lead to better functional improvement compared to the patients who just got the HTO and a standard meniscectomy cleanout.
That is a massive takeaway for counseling patients. So you're saying if the patient is varus and symptomatic, correcting the alignment, the HTO did all the heavy lifting for symptom relief.
The mechanical correction had the overwhelming effect. It suggests that the scaffold's benefit, if it's there, is probably purely about long-term chondroprotection, not short-term pain relief, at least when you're also doing a big realignment.
Okay, so since CMI is biological and ActiFit is synthetic, everyone wants a head-to-head comparison. The data is pretty sparse, though.
Very sparse. Spencer et al. Gave us one of the only direct comparisons. It was a small series, but they looked at both scaffolds, and they found that the ActiFit group showed earlier filling of the defects at the 1-year second-look arthroscopy.
That's interesting. So does that mean the engineered controlled porosity of the synthetic material allows for faster cellular infiltration?
That's the leading hypothesis, yeah. A more reproducible architecture might just facilitate earlier ingrowth. But, and this is a big but despite that difference at 1 year, the overall clinical outcomes, the functional scores, they were comparable and satisfactory for both groups in the short term.
So the question that remains is which one provides better chondro protection 15 years from now? And we just don't know yet.
We don't have that answer yet for ActiveFits.
Okay, let's talk about a complete paradigm shift. We've been talking about regeneration using a template to rebuild. Usurface takes the substitution approach. It's a non-degradable permanent implant that just sits in the joint. It's not even sutured in.
Yeah, this is aimed at a very specific clinical problem. ME, or meniscal allograft, is the standard for a subtotal meniscectomy, but it requires a lot of biological healing capacity. So it's not always ideal for, say, middle-aged patients whose biology isn't as robust. New Surface is designed to just substitute the function of the missing meniscus in that older, symptomatic group.
The term free-floating is what makes every surgeon immediately a little nervous. A permanent unanchored implant sounds like a recipe for the knee locking up or the implant migrating.
It's definitely a risk, which is why, again, patient selection is everything. It still requires an intact peripheral rim for containment. That rim basically acts as the soft tissue barrier to keep it in place. The implant itself is shaped like a discoid meniscus and is put in through a mini arthrotomy.
So how do you convince a patient that this unanchored piece of plastic won't cause problems? We need the biomechanical validation here.
The material properties are key. It's a polycarbonate urethane with viscoelastic properties that are designed to mimic the native meniscus. And to address those wear and stability concerns, they did some really rigorous testing.
Tell us about the wear test.
They simulated 5 million gait cycles. That's about 5 years of in vivo loading. It's a massive stress test. And the implants held up really well with a very low wear rate. That suggests it's highly durable and probably won't generate a lot of problematic wear debris.
Okay, so low risk of debris-related inflammation. What about the kinematics? Does it mess with the knee's natural movement?
A pilot study using open MRI looked at that, and the results were pretty encouraging. The implant didn't seem to negatively impact femoral rollback or the tibiofemoral contact mechanics. It maintained that crucial load distribution.
So it moves around a bit more than a native meniscus, but it keeps the contact area, which is what protects the cartilage.
That seems to be the mechanism. But the critical long-term unknown is whether that peripheral rim will remain strong enough 15 or 20 years later to keep the implant contained.
Which is why the definitive clinical data is so important.
And that's being collected right now. The Venus clinical study is a large, multi-center randomized trial comparing New Surface against the traditional non-surgical standard of care NSAIDs, PT, steroid injections, that sort of thing. The results of Venus will really define if this is a viable path for that difficult middle-aged demographic.
Okay, so now let's move into the realm of what feels like bioengineering fantasy, but is quickly becoming reality. We're looking beyond these passive scaffolds and toward truly active biological implants.
This is where the science gets really exciting. CMI and ActiveEd are essentially passive. The next step is to turn them into active bioreactors by, seeding them with cells to accelerate and improve the quality of the regeneration.
What are some examples of how people are trying to do that?
Well, one way is by combining materials. So using scaffolds made of hyaluronic acid combined with a stronger polymer like polycaprolactone or PCL. The HA provides the biological environment, and the PCL provides the structural stability.
So you're blending the biological invitation with the mechanical strength.
Exactly. Another even more powerful approach is cell seeding. Kahn and his group showed that pre-seeding scaffolds with a patient's own chondrocytes had a really positive effect on tissue formation in sheep. You're basically giving it a head start with the right cell type.
And then there's the use of stem cells.
Angeli's work showed great promise using scaffolds seeded with marrow-derived mesenchymal stem cells, or MSCs. In rabbit models, they saw much better tissue ingrowth and higher quality matrix compared to the acellular controls. MSCs are like the raw construction workers of the body. Delivering them right to the site just supercharges the whole process.
This is all moving us closer to truly mimicking the native tissue, which brings us to the ultimate goal, what you called the apex of zonal regeneration.
This is the holy grail. To truly succeed, you have to replicate that precise gradient. Type I collagen on the outside for tension, type 2 on the inside for compression.
Yeah.
The scaffold needs to have not just the right shape, but the right biochemical instructions.
It sounds like you're trying to program biological software.
That's precisely what Lee et al. Achieved in their groundbreaking work back in 2014. They 3D printed a meniscal scaffold from polycaprolactone that was anatomically perfect, but the real breakthrough is how they functionalized it.
How do they manage that zonal programming?
They engineered these tiny microparticles that contain specific growth factors, connective tissue growth factor, CTGF, and transforming growth factor 3, or TGFA3. And then they incorporated these microparticles into different zones of the scaffold during the 3D printing process.
So the scaffold itself was delivering these very specific biochemical instructions to the cells that migrated in.
And crucially, the factors were released spatiotemporally, at the right time and in the right place. They guide the progenitor cells to differentiate based on their location. So CTGF in the periphery promotes a fibrous type I collagen. TGF3 in the inner zone promotes a chondrogenic type 2 collagen.
They are literally providing the construction manual to the cells. The result in the sheep model must have been stunning.
It was the gold standard. The endogenous cells regenerated zone-specific matrix. They had type I collagen in the outer zone and type 2 in the inner zone. The process actually restored the inhomogeneous mechanical properties of a native meniscus. That is what true biological integration looks like.
Okay, let's pull all this incredible science back to the clinic. Based on all the data from CMI and ActiFit, what are the common denominators that consistently lead to poor outcomes?
The data is really unified on this. 3 factors, over and over, predict failure. 1, increased BMI, specifically over 25. That's just a mechanical loading issue.
Yeah.
2, multiple concomitant procedures, which suggests a need that's already just too far gone, too mechanically challenged. And 3, the chronicity of the lesion. An older, more scarred defect just has less biological potential.
Which reinforces the idea that we can't perform a miracle on a knee with severe comorbidities. We have to be meticulous in our patient selection and make sure any primary mechanical driver, like malalignment, is addressed first.
Absolutely. The HTO data proves that. Correct the alignment and you'll often get symptomatic relief with or without a scaffold.
And finally, the big $64,000 question. We know we can grow new tissue with CMI and ActiFit, but what remains the crucial long-term unknown?
The actual function of that newly formed tissue. While we have encouraging 10-year data showing less joint space narrowing with CMI, the definitive long-term ability of this new tissue, say, beyond 10 or 15 years, to genuinely protect the adjacent cartilage from degenerating, that remains unknown.
So is it a structurally sound bridge that can only handle light traffic, or can it really withstand the heavy daily pounding of an active life?
We just don't know the long-term load capacity of this new meniscal tissue, which is why the next step for all these technologies is continued, prospective, randomized trials with follow-up that extends well beyond the 10-year mark.
So to summarize our deep dive, we've really looked at the 3 major clinical pathways for meniscal deficiency. There's the collagen meniscal implant, CMI, using that bovine template to regenerate tissue with demonstrated 10-year survival.
Then there's the ActiFit scaffold, using synthetic polyurethane to do a similar job, maybe with faster initial filling.
And then new surface, which is a totally different non-anchored substitution approach for that middle-aged patient.
And the unifying theme across all of them is the absolute necessity of that intact peripheral rim for containment and stability. Without that critical structure, none of these materials can survive in the joint.
The future, though, seems incredibly bright. It's in that preclinical work, the 3D printed scaffolds that deliver spatiotemporal biochemical cues to regenerate zone-specific tissue, a true attempt to mimic how the body does it in the first place.
And that leads us to our final provocative thought. The body develops the meniscus naturally through this gradual, highly organized process of vascular regression and changing tissue composition. Can we ever truly succeed in restoring a permanent meniscus in a hostile adult mechanical environment until we can fully mimic that exact developmental blueprint?
The challenge isn't just rebuilding the structure.
It's not just the structure. It's about replicating the specific biology necessary to survive the knee's brutal loading environment. The scaffold is just the construction site. The biology is the fussy architect, and we are only just now starting to be able to read its mind.
A perfect way to frame the future of orthopedic bioengineering. Until next time, maintain meticulous surgical standards and keep asking the hard questions about that long-term data.